name is Chelsea Horn. I'm a third-year emergency medicine resident with Correspond Texas A&M Corpus Christi, presenting my research titled Hispanic Patient Knowledge of Hypertension, a Survey of Emergency Department Patients. I'd like to recognize my co-authors, Dr. Xu, McLaughlin, Torres, and Richmond. I have no financial or non-financial disclosures. 45% of adults in the U.S. have hypertension, which is defined as a systolic blood pressure greater than or equal to 130 or a diastolic blood pressure greater than or equal to 80. Only about 1 in 4 adults with hypertension have their condition under control. Rates of high blood pressure control varies by race. Hypertension control rates are highest among non-Hispanic whites and lowest among non-Hispanic Blacks, Hispanics, and non-Hispanic Asians. In regards to the Hispanic population, they're the largest growing demographic group in the U.S. They're the country's second largest racial or ethnic group, behind non-Hispanic whites. Among U.S. Hispanics or Latinos, the epidemiology of hypertension has not been adequately described. Hispanic adults have some of the highest prevalence of poorly controlled blood pressure compared with any other race or ethnic group in the U.S. Causes of ethnic or racial inequalities are multifactorial, but can be largely attributed to medication noncompliance, substandard insurance coverage, and poor access to health care. Poor control in Hispanics may also be attributed to low hypertension awareness when compared to non-Hispanic whites, which brings me to the objective of my study: to assess the knowledge of Hispanic versus non-Hispanic emergency department patients regarding the hypertensive disease process, management, and risk of complications. In order to address disparities, we need to know what the patient doesn't understand regarding their disease process. This was a prospective cross-sectional study performed in an urban academic setting in South Texas. The population consisted of a convenient sample of consenting, stable ED patients. There was also a retrospective component involving EMR review. Participants with a documented or given history of hypertension were enrolled by trained research assistants. They were then asked to complete a structured survey that utilized questions modified from a previously published survey instrument developed by Oliveira et al. Participants were excluded if they were unable or refused to provide informed consent, were disoriented, or medically unstable. After survey completion, the investigators performed a chart review in the Christus Meditech system for diagnoses of hypertension or related processes. The survey looked at specific demographic factors such as age, gender, level of education, race or ethnicity, and income. It also looked at whether or not the patient had an established primary care physician, if they are currently being treated for their diagnosis, and if so, how many medications they were requiring. Participants were asked to answer multiple choice questions regarding the definition of hypertension, the disease's effects on health, the normal systolic and diastolic measurements, lifestyle factors, and how they understood asymptomatic hypertension. Statistical methods utilized included chi-square to analyze categorical data, as well as t-test to analyze continuous data. All tests were two-tailed with alpha set at 0.05, and 228 patients were enrolled in the study group. The groups were similar with respect to the percent of female gender, percent with primary care physician, and number of BP meds. There were no significant differences between the two groups regarding the definition of hypertension, understanding that lower blood pressure improves health, and recognizing that individuals can do things to lower blood pressure. If asymptomatic, 63% of the respondents would go to the ER for systolic blood pressure between 150 to 190, while 25% would go if their systolic blood pressure was greater than 190. If asymptomatic, 63% of respondents would go to the ER for a diastolic pressure between 90 to 120, and 19% would go only if their diastolic pressure was greater than 190. The following characteristics were different between the two groups: age greater than or equal to 60, less than a high school education, or an annual income less than $15,000. There was a significant difference between non-Hispanic whites and Hispanic patients' knowledge of the recognition that hypertension is somewhat harmful or harmful, recognition that normal systolic blood pressure is less than 140 and normal diastolic pressure is less than 90. By way of discussion, it's important for healthcare providers to be aware of specific cardiovascular health risks that are unique to this population, as Hispanic Americans have an increased cardiovascular risk when compared to non-Hispanic whites. Hypertension is the most common risk factor for cardiovascular disease, surpassing smoking, obesity, and diabetes. There's a paucity of research regarding Hispanic health literacy in cardiovascular diseases. The emergency department is more likely to serve as an entry point into the healthcare system for racial and ethnic minorities, as they are more likely to rely on ED services for routine healthcare needs. Efforts to prevent the development of hypertension and improve rates of hypertension treatment and control among U.S. Hispanics and Latinos require broad-based public health strategies. The emergency department serves a valuable service for this population, for treatment, education, and intervention. Because of this, it's important that we understand our patients' basic knowledge of their hypertensive disease process. In summary, Within our study group of Hispanics versus non-Hispanic whites, both groups demonstrated understanding of the definition of hypertension, that lower blood pressure impacts health status, and that the individual has the ability to influence blood pressure control. There was discordance between the two groups regarding knowledge of the normal systolic and diastolic measurements and the recognition that hypertension can be harmful. In terms of limitations, patients surveyed may not have been in the ED for a complaint related to their hypertension. Hispanics and non-Hispanics were dissimilar for some characteristics, and the survey instrument was offered only in English, thus excluding a subset of the population of Hispanics for whom Spanish is their primary language. In conclusion, when compared to non-Hispanic whites, Hispanics were less knowledgeable regarding normal BP levels. However, we did not find a significant racial difference within the majority of study group patients who reported that they would go to the ED for asymptomatic hypertension below thresholds typically considered medically emergent.
Hi everyone, my name is Laura Seawald, and I'm a fourth-year emergency medicine resident at the University of Michigan, working with my co-authors here at the bottom. We also represent the Firearm Safety Among Children and Teens Consortium, and today I'm talking about the rates of firearm safety counseling among a nationally representative sample of teens and their parents. I have no conflicts to report, and our project is funded by the NIH/NICHD. In terms of background, firearms are the second leading cause of death for children and teens. We know that screening and counseling interventions by healthcare providers, or HCPs, have been shown to improve safe firearm storage in the homes of children and teens. However, screening and counseling rates remain low despite the recommendations from national medical associations. Additionally, little research is focused on the patient perspectives and or their experiences regarding screening and counseling practices, and very little research has been conducted using a nationally representative sample. So the goals of our project was to estimate the proportion of parents and teens who discuss firearm safety with the teen's healthcare provider. We also wanted to examine any safety changes that were made in response to counseling and understand the perceived importance of healthcare counseling around firearm safety. To do this, we used a nationally representative sample of parents of high school age teens, age 14 to 18, and the teens themselves, using a web-based cross-sectional survey conducted by the survey group Gallup. This was done between June of 2020 and July of 2020, and the University of Michigan and Gallup IRBs both approved our study procedures. In total, we had 2,924 parents and 2,000 teens age 14 to 18 participate in our study, with approximately 95% of them reporting that they have a healthcare provider from whom the teen receives regular counseling. So when parents and teens were asked which health and safety topics their healthcare provider had discussed with them in the last 5 years, the most commonly discussed topic was teen mood, which was around anxiety and depression, followed by alcohol and drug use and teen sex. The least common discussed topic was gun safety, with only 15% of parents and 10% of teens reporting that the teen's healthcare provider had discussed this with them. Among the parents who reported their teen's healthcare provider had discussed gun safety with them, the most commonly discussed topics were whether there was a firearm in the home, whether these were stored in a locked place, and whether they were stored unloaded. The least discussed topics were storing firearms away from the home if the teen was at depressed or risk of harming themselves, or if they're at risk of harming someone else. So among the parents who did receive gun safety counseling, less than 10% of them reported any changes to their firearm safety practices. For those who did report any changes, the most common change was simply discussing firearm safety with the teen, and then followed by moving the gun to an inaccessible part of the home. The least common changes were starting to use a safe storage device or a lockbox that they had already bought or purchased, removing the gun from the home permanently, and no one used a safe storage device that had been provided to them by the teen's healthcare provider. In regards to the perceived importance about firearm safety counseling, less than 30% of parents and teens even agreed or strongly agreed that this was an important topic for the healthcare provider to discuss. However, teens were slightly more agreeable to discussing this, to thinking this was an important topic to discuss than adults. And then when comparing the perceived importance of firearm safety counseling between non-firearm owning and firearm owning households, it was statistically significant with a p less than 0.001 that there is a higher perceived importance to discuss firearm safety among non-firearm owning families. When looking at the relationship between healthcare providers and the families they counsel, there was generally a high trust for the healthcare provider to discuss general health safety topics and vaccines. However, there was a much lower trust for the healthcare provider to counsel around firearm safety. In terms of limitations, this is a nationally representative sample of parents and their teens, so conclusions specifically pertain to families with teenagers at a high school age and not the full range of potential parents and or teens who may receive counseling. Additionally, there's the potential for social desirability and self-report bias. For implications and conclusions, our results suggest that healthcare providers should normalize more regular counseling about firearm safety, just as we do with teen mood and drug and alcohol use. To do so, a lack of trust in providers will likely be a key barrier to address and consider. And we should also focus on increasing provider competency around firearm safety to deliver more effective counseling. Finally, though healthcare provider counseling is one way to help improve firearm safety, we also will ultimately need to look for multifaceted and novel approaches with a variety of stakeholders to actually implement better firearm safety practices for our patients. And with that, I believe we'll have some time for questions, and I thank you for your time.
Hello, everyone. My name is Dean Hayes, and I'm a current second-year medical student at the University of Cincinnati. And I'm here to present to you on the project Identifying Modifiable Reasons for Leaving Against Medical Advice Among Patients with Opiate Use Disorder. This project was done out of the Department of Emergency Medicine at the University of Cincinnati. And actually, the reason I got involved with this project is because I used to be a nurse prior to enrolling in medical school at the emergency department at UC. So I have nothing to disclose and some background information. So patients with opiate use disorder, I'm sure as many of you are aware, are up to 4 times more likely to visit an emergency department, and they have an increased total cost of care with estimates ranging between $5,000 and $20,000 annually. And they are more likely to leave against medical advice from both the emergency department as well as inpatient units. Now, patients who leave against medical advice from either the ED or inpatient facilities have increased morbidity, mortality, 30-day readmission rates, as well as cost of care. So we had 2 study objectives. The first was to characterize why patients with opiate use disorder leave against medical advice from the emergency department. And our secondary objective was to report how often OUD or unmanaged symptoms directly contributed to leaving AMA. Here are some definitions that we use in the study. So for opiate use disorder being directly linked, we said that there had to be clear documentation that the patient was leaving due to a plan to use opioids, concerns about legal consequences related to their opioid use, or a disagreement with the care team about regarding their opiate use disorder. And then for unmanaged symptoms, we use the definition of clear documentation that patients complained of pain, nausea, vomiting, agitation, other symptoms associated with withdrawal, and that they requested medications to address the above complaints. So to hop into the methods, this was a retrospective chart review utilizing a mixed method approach. Our inclusion criteria was ED encounter between January of 2016 and December of 2019, and we utilized ICD-10 codes and a final ED disposition to identify patient records. There was no exclusion criteria, so we ended up with a patient population for the study of patients with opiate use disorder who had left the emergency department against medical advice. All the charts were dual abstracted. One abstractor was a person with emergency department nursing experience, and another was one of our current residents in the emergency medicine program. And Kappa statistic was used to assess the inter-rater reliability. We also created a list of reasons for leaving against medical advice, reasons that we thought based on our literature review that might come up during the abstraction. So this list was created prior to abstracting any of the charts and was available for the abstractors to choose between. And then for our secondary objective, whether OUD or unmanaged symptoms contributed directly to leaving against medical advice, the abstractors had either yes, no, or unclear to choose from. So for yes, there had to be clear documentation that either OUD or unmanaged symptoms contributed to AMA. No, being there was clear documentation that there is something else they were leaving for example, picking up a child from school. And then unclear would have been whether the abstractors couldn't make a determination based on what was explicitly written in the chart. So the results, we had 186 records reviewed with a median age of 33. And you'll note that the vast majority of patients were both white and male. And this is about representative of what we see with the opiate use disorder population here in Cincinnati, Ohio. And then you'll see that for our primary objective, about 47% of people who left AMA believe that there was a low risk for poor health outcomes. And then I will point out, we did have a large other category, and this was composed of a bunch of smaller categories that didn't reach 5% that you can see on the right-hand side of your screen. And then to address our secondary objective of whether OUD or unmanaged symptoms directly contributed to AMA, you'll see that for opiate use disorder, we believe it directly contributed 12% of the time, and it was unclear 68% of the time. And for unmanaged symptoms, that contributed directly 8% of the time and unclear 56% of the time. The remaining values to equal 100% was the answer no. And then you'll note that we had moderate kappa scores, indicating moderate agreement between the two abstractors. So there were some limitations to this study. Current AMA documentation is poor regarding patient circumstances, and we believe that prospective data would be better to characterize the motivations that patients have for leaving against medical advice. And then this retrospective review also relied on the care team's interpretation of why patients were leaving. There wasn't necessarily like a standard set of questions that providers or nurses were able to ask patients prior to leaving. And so a lot of times the documentation relied on their interpretation. So in conclusion, nearly half the patients who left against medical advice expressed a belief that they're unlikely to experience any poor health outcomes due to this decision. And unfortunately, we know this is just not the case. They're, like we talked about in the background information, much more likely to experience poor health outcomes. And then second, we found that opiate use disorder and unmanaged symptoms are contributing in this patient population for leaving against medical advice. And so these two things were directly linked in many of the cases. What we found in the study was unfortunately likely an underestimation given our limitations and the number of unclear charts that we found. And then we think this demonstrates that there's a need to develop interventions to help keep this patient population safe because they are so vulnerable and at increased risk for negative health outcomes. So with that, I will conclude and thank you for your time, and I'll open up for any questions.
Hello, I'm Robert Adrian, one of the third-year emergency medicine residents at Rutgers, New Jersey Medical School. Our abstract is called Emergency Department Safety, assessed by the 12-question Violence Risk Self-Assessment Checklist Tool. My fellow author is Dr. Maureen Gang. A quick warning, I have included several non-graphic photographs throughout this presentation of healthcare workers killed by workplace violence. Because this may be triggering, I want to pause for a few seconds to honor them and to give those who do not wish to continue a chance to step away. I'm going to move forward. I have no disclosures. For background and objectives, ED workplace violence is pervasive. According to the U.S. Bureau of Labor Statistics, during the 10 years between 1980 and 1990, 26 physicians, 18 nurses, 27 pharmacists, and 35 other healthcare workers were killed while at work. And during the 5 years between 2011 and 2016, 58 hospital workers died from workplace violence. Quantifying aspects of safety could help guide improvement. However, no survey has yet been validated for this. We piloted the not yet validated 12-question violence risk self-assessment checklist tool to assess perceived risk of violence among staff working in a public, urban, academic medical center. This subjective tool was created by Patricia Allen in her book, Violence in the Emergency Department, where she adapted her questions from expert opinion. An important part of this survey is assessing important aspects of safety that may be lacking, but also to obtain staff knowledge on existing features. For methods, this was a quality improvement study. We conducted a review of anonymously completed 12-question violence risk self-assessment checklist tools by ED staff in Qualtrics from December 2019 to March 2020. Data were analyzed using descriptive statistics. Allen assigned questions a range from 0 to 30 points, with a maximum total score of 165, and determined total scores greater than 50 indicate an ED at perceived risk of violence. For results, we received responses from 67 staff members, 23 residents, 16 unspecified, 3 PGY1, 1 PGY2, 2 PGY3, 1 PGY4 who were specified, 9 attending physicians, 25 nurses, 4 medical technicians, 2 APNs, 3 clerks, and 1 other who did not specify their role. We have 34 residents in our program and 39 attendings in total. 96% of staff had scores greater than 50, and 94% felt unsafe at work. The average score was 126. Of note, although our ED does have panic duress alarms governed by policy, only 49% of staff were aware of them. For conclusion, this non-validated survey suggests that staff working in a public, urban, academic medical center assess that they are at significant risk for violence at work. A limitation is that some items are open to interpretation and have no comparison to actual risk. Since this survey, we hired a new security agency, reassessed our visitor policy, and educated our staff on existing safety measures. We hope to follow up this by resurveying staff and assessing comparable medical centers' responses to this questionnaire, given high rates of ED workplace violence nationwide. Thank you.
Hello, I'm Patrick Carter, and I'm going to be speaking today about optimizing an adaptive behavioral intervention for violently injured youth using reinforcement learning. I don't have any disclosures other than to acknowledge my collaborators on this project, as well as my funding from NIH. By way of background, homicide is the third leading cause of death for all U.S. youth and the leading cause of death for African American youth. As emergency department physicians, we see over 600,000 patient visits every year among adolescents for non-fatal assault injuries. And the youth that we see in the emergency department with an initial assault injury have high rates of return within 2 years, almost 37% return for a second violent injury, often more severe than the first, within the next two years. Almost 60% are also involved in firearm violence, in some ways the aggressor or the victim, and almost half are involved in the criminal justice system within that 2-year period. So there's an entire field of violence prevention research that's focused on what can we do with that initial visit for a violent injury to prevent these subsequent violent injury outcomes. And there's a number of interventions that have been developed. Most of them involve some type of combination of care management or care management and behavioral therapy in order to try and affect these outcomes. They're focused primarily on a one-size-fits-all model of a number of intervention sessions that are delivered to the youth who's enrolled in the study. And there is some signal that these types of interventions can decrease these violent outcomes. But what we also see in that data is that this one-size-fits-all approach of a set number of sessions delivered to an individual may not be the best approach for all youth. Some youth may need more intensive intervention. Some may need only a few sessions and be able to taper off after that. So newer approaches to these types of interventions are using what are called adaptive intervention models, where we can adapt the type of intervention content, the delivery modality of the content to be personalized to the youth to deliver the right type of content at the right time to have the right outcome and not any more than is needed. These just-in-time adaptive interventions require some type of algorithm to direct the adaptions that are made in the intervention content. One example of that is an artificial intelligence-derived algorithm called reinforcement learning. Reinforcement learnings adapt the treatment regimen by optimizing a single numeric score called a reward function that summarizes both the patient's progress to date and their response to the intervention content. So the objective of the analysis I'm going to talk about here today was to develop this type of reward function to optimize the algorithm that's encased within a just-in-time adaptive intervention that's addressing violent injury recidivism among youth who are in the emergency department for an index violent injury visit. So we took data from another pilot study of 50 youth who were enrolled in a daily diary study, and they completed 30 questions over a period of 30 days. So we had a total of 908 daily observations among the 50 youth who were enrolled. And we examined the association of a number of candidate variables that were derived based on empirical data from prior studies or prior intensive longitudinal analyses, and looked at their association with same-day fighting in a logistic regression model. So what differentiated days where they had a fight versus days where they didn't have a fight? And then we took those candidate variables and we removed them one by one in order to determine what was the minimum number of candidate variables we needed within a model in order to have the best discriminatory power for detecting fighting on that day. And so the candidate variables are at the left, you can see here, and you can see that on the right, the key derived variables that resulted from our stepwise logistic regression model were firearm carriage, a 3-level variable of no carriage, carriage, or carriage in a risky way, such as under the influence of alcohol. A self-report of anger, prosocial behavioral involvement, which was reverse coded, and an index of substance use for that day. Using that as the key derived variables, we also added in several variables that we couldn't include in the original logistic regression model, either because they weren't in the initial study or because they were the proximal outcome measures of fighting. So that included self-efficacy for not fighting, which wasn't measured in the original pilot data, aggression and victimization, or violent injury requiring emergency department treatment. This 7-item score was then weighted, and we weighted evenly between those that are considered outcome variables for the study, violence, violent injury, substance use, and firearm carriage, and then key mediator variable elements, so prosocial behavior involvement, self-efficacy, and anger, to create essentially a 100-point reward score. This final 7-item reward score that we created demonstrated good day-to-day variability, with about 50% of the variation occurring within individual and about 50% occurring between individual. And the final score, when aggregated across the 30-day daily diary study, the mean scores demonstrated good correlation with 3-month outcomes of aggression and victimization, which are the outcomes for the larger randomized control trial. So in conclusion, the score that we were able to derive shows promise as a RL reward function for assessing both treatment response and to guide an adaptive treatment regimen within a just-in-time adaptive intervention for youth violence, which we are currently enrolling youth in the emergency department, in several emergency departments. So we'll have more outcome data at a later point in time on whether or not this reduces violent injury recidivism and whether or not this type of reward score can be used to optimize treatment algorithms and reduce overall cost of delivering these types of individual.
Hello, everyone. My name is Michael Valdivia. I am a current second-year medical student here at the University of Cincinnati College of Medicine, and I will be presenting my research, which is the performance of the HEART score versus EDAX among patients with a cardiac evaluation in the emergency department, a prospective 90-day observational study. I did my research under my principal investigator, Dr. Gregory J. Furman, as well as Dr. Yui Stoles, who was the main statistician for the project. Disclosures: I have no financial disclosure or conflicts of interest in this presentation. To start off with, let's talk about a 65-year-old male who presents to the emergency department with a chief complaint of chest pain. This patient is one of 6 million patients who present to the ED with this chief complaint annually, and this is pretty concerning because of something called acute coronary syndrome, or ACS, which is when there is a narrowing or reduction of blood flow in the coronary arteries that causes that classic chest pain, nausea, and shortness of breath. These symptoms can lead to ischemia involving the cardiac tissue, and this is a medical emergency, as ACS can lead to death or severe disability within these patients. The question is, do all patients who have chest pain have ACS? No, there is a wide spectrum of differential diagnoses needed to be considered. Therefore, it is up to the emergency physician to determine who is sick versus not sick. To help out, there have been several risk stratification tools developed to identify low-risk patients versus high-risk patients. In 2008, the HEART score was developed, and more recently in 2014, the EDAX score was created. How these scores work is that with each category, depending on the patient's presentation, they get a score. Their score can be tallied up, and then depending on the total score that they get will determine whether or not they are with low risk, such as with the heart score, anything 0 to 3 is low risk, and anything 7 to 10 is high risk, or with EDAX, anything less than 16 is considered low risk, and anything greater than 16 can be considered high risk. And these can be used for the emergency physician to determine whether or not the patient can be discharged or admitted. Both of these scores have been externally validated through multiple studies and systematic reviews. The heart score has high sensitivity with very low risk patients experiencing a major adverse cardiac event. A MACE is any time the patient has hospitalization because they had an MI or needing an emergent revascularization procedure or stuff like stroke. EDAX has identified a higher percentage of patients as low risk, but within those patients, there are slightly more low-risk patients who did actually end up experiencing a MACE. There are a few prospective studies that directly compare the two prediction models, and most of these only look at MACE within 30 days. Therefore, there is incentive to test these models against a longer period of time, such as 90 days, which is the goal of our study. We want to look at the heart score and EDAX and the identification of the 90-day MACE, with our alternative hypothesis being that the heart score will be the superior prediction model, and the null being that both models can predict MACE equally well. The data for our study came from this Magnet ACS study, which was supposed to evaluate the rate of MACE within 90 days of patients suspected of ACS using this device right here. Unfortunately, the study was terminated early because of device algorithm failures. However, the data was released and we wanted to continue to use it for something. Therefore, we pivoted and decided to, again, compare heart versus EDAX in the identification of 90 days MACE. As we can see here, we had 651 patients enrolled. Of those patients, only 476 were actually followed up within 90 days. And of that patient population, only 472 actually had a heart and EDAX score recorded. Here are some subject characteristics of our data. Of note, 35.6% of these patients came with a prior cardiac history. 9.3% of patients were actually diagnosed with ACS. 4% did have a MACE event occur, and about 1% did die within the study. If we look at the EDAX and heart distributions of the score, we can see that EDAX had a median value of about 11, which again is low risk, and heart had a median value of 4, which is within that intermediate risk zone. Looking at the data in regards to the odds ratio, we see that heart score is associated with MACE while EDAX is not. We saw that the odds ratio for MACE per 5-point increase in the EDAX score led to an odds ratio value of about 1.3, but given the confidence interval value as well as our P, it was not statistically significant, whereas the odds ratio for MACE per 1-point increase in the heart score led to an odds ratio of 1.7 and was statistically significant. When we plotted the area under the curve for MACE, we saw that the heart score did have higher discrimination compared to EDAX. Once again, if we look at the heart score, which is this blue line right here, we saw that it had a value of 0.78 with the confidence interval shown right here, but the EDAX had a value of while the EDAX had a value of 0.606, its confidence interval fell within that 0.5 range, making it not as discriminatory compared to heart. Next steps, what we want to do is we have some troponin data. We can analyze something called EDAX ADP, which is again another type of prediction models. We have some other prediction models that we can go against too, and we might even identify a new risk stratification tool. With that, I would like to acknowledge Dr. Furman and Dr. Stoles, and I will be taking any questions at this time. Thank you.
Hi, everyone. My name is Joshua Neferadis. I am an emergency medicine resident at the Johns Hopkins School of Medicine. And today we'll be presenting our abstract that was accepted to SAEM. So really quickly, we have no disclosures, and our team comes from Ali Raja, who's at Massachusetts General Hospital EM, as well as the rest of our authors who are from University of California, San Francisco Department of Emergency Medicine. So we're looking at vaccine hesitancy in the United States. And so 50 to 80% of the US needs to be vaccinated to achieve herd immunity. Those are the most recent estimates. However, 26 to 44% are hesitant to get the COVID-19 vaccine based on previous survey studies. So the clinical question that we had for our study was, why are people hesitant to receive a COVID-19 vaccine? To kind of look more in detail, semi-qualitatively. So our primary outcome was more or less COVID-19 vaccine hesitancy, which we define as either non-acceptance or being unsure about acceptance if they would actually get the vaccine. Our secondary outcome were predictors of hesitancies and reason for hesitancy. So we conducted a survey that we put on Amazon Mechanical Turk, which has been done in a lot of other survey studies published in the medical literature, but more specifically in the social sciences and psychology, and is fairly nationally representative. So this was a cross-sectional study that was done November 17th to the 18th of 2020. And note, this was prior to EUA approval of the Pfizer mRNA vaccine. Our inclusion criteria was anyone 18 to 88 years old, and our exclusion criteria was anyone living outside the US or who was a healthcare worker. We constructed our survey, piloted it among us, and things that were included were demographics, health insurance and utilization, political affiliation, previous influenza vaccination, as well as if they would want the COVID-19 vaccine or not. So very succinctly, since this has to be a short presentation, the COVID-19 vaccine, for those who answered yes, no, or unsure, we had a total of 1,786 adult respondents. 30 were excluded for poor quality responses. Here we can see that 62.2% of all the respondents said that they would want a COVID-19 vaccine. 21.3% said they would refuse a COVID-19 vaccine. And 16.5% were unsure if they would want a COVID-19 vaccine. Notably, though, most respondents were white, 77%, 38 years old, with an interquartile range of 31 to 48. And 85% of individuals had health insurance, and 78% reported regular access to medical care. So take that into consideration when we get to our limitation section. In our multivariable logistic regression analysis, where we had refusal or uncertainty as a combined variable versus acceptance of the COVID-19 vaccine, predictors of refusing the COVID-19 vaccine were previous refusal of a flu vaccine, if they self-identified as female, if they self-identified as Black compared to white, Hispanic, Asian, or other, as well if they had a high school education or less, and if they self-identified as Republican as opposed to Democrat or Independent. We put this persona graph plot together after we did a classification tree analysis using machine learning, and it's kind of cool because it can kind of give you a general breakdown of the main predictors that came out of the classification tree analysis, so which you can see on the left right here. Those who will get the COVID-19 vaccine is primarily those who are Democrat and those who had received the influenza vaccine previously. And those unlikely, as you can see here, we see a shift to more Republicans and independents, as well as those who had not received the influenza vaccine earlier. So the top 3 reasons for refusing vaccination, many people were concerned about side effects and safety of a COVID-19 vaccine. Majority also reported they just wanted more information about the vaccine itself. And then 17% were actually unconvinced that it would be effective. So some limitations to this study is our sample population. Although it's been validated in a lot of other contexts, having it be 38 years as the median age, as well as mostly white, as those who are, primarily college educated, obviously limits the generalizability of the study significantly. You can't calculate a response rate for Amazon's Mechanical Turk. It's more or less those who want to take the survey can take the survey. And then obviously this is just hypothesis generating as opposed to looking for causation. So conclusion, obviously it's highly concerning though, regardless that you have almost 30% of individuals or 38% of individuals who are uncertain or would refuse the COVID-19 vaccine, especially when we think about what is needed for herd immunity. going forward, I think it would be a good idea to focus on target populations that have hesitancy regarding it, such as those that maybe have less of an education, high school education or less, or who identify as being Republican. And obviously, it's building trust with our communities. There's been a number of other survey studies that have been published since our study was published that have also shown that individuals who self-identify as Black are less likely to want the COVID-19 vaccine. And obviously, there's strong historical roots and distrust in the medical establishment and the scientific establishment among this population. And I think we need to do a better job at building that trust. Thank you for coming to this presentation. I wish I could be there in person to answer any of your questions. Have a good day.
Hello, everybody. My name is Cole Wymore, and I am an Assistant Clinical Research Coordinator in the Emergency Department at the University of Iowa Hospitals and Clinics. Today, my presentation will focus on age-dependent differences in playground slide-related injury mechanisms among young children. First, I would like to take a moment to thank my colleagues listed below for their contributions to this project. The authors have no financial disclosures. Playground slides continue to be a popular apparatus for childhood play and a frequent cause of childhood injury. Yet, few studies have examined the mechanisms and injuries associated with slide-related injuries in preschool children. The objective of our study was to better understand the mechanisms associated with slide-related injuries in young children. To do this, the National Electronic Injury Surveillance System, or NIS, database was utilized. NIS is a system that prospectively collects injury data from a stratified sampling of emergency departments from across the country. Over 1,400 cases of playground slide injuries in children 5 years and younger from 2002 to 2017 were identified. Database narratives were then used to code the mechanism of injury for each case. Descriptive and bivariate comparative analysis were then performed. After coding the mechanism of injury for each case, several common mechanisms were identified, which are listed below. Falls were the most common cause of slide-related injuries, occurring in 62% of cases. The next most common mechanism was injured on a slide mechanism unknown. This category was comprised of cases for which there was an insufficient amount of detail in the database narrative to identify the specific mechanism that caused the slide-related injury. The next most common mechanisms were injured while going down the slide on a lap, which represented 6% of the cases, and injured when the foot or leg caught on the slide, occurring in 5%. Although the demographics and injury pattern observed in cases with this mechanism suggest that these were mostly lap-related injuries. I wanted to include this image to illustrate what a lap-related mechanism looks like. Here we can see a young child positioned on the adult's lap. As the parent and child are going down the slide, the child's foot catches the side of the slide, but the adult's momentum still carries them forward, resulting in a twisting force being applied to the child's lower extremity. In regard to fall mechanisms, in 44% of the cases, this mechanism resulted in injuries to the head, face, or neck, and upper extremity injuries were sustained in 40%. Additionally, fall mechanisms were associated with a significantly greater percentage of brain-related injuries, and a significantly higher proportion of cases with a fall mechanism required hospital admission or transfer compared to other mechanisms. In regard to non-fall mechanisms, there were a higher proportion of musculoskeletal injuries compared to other mechanisms, occurring in 60% versus 47% of cases respectively, and musculoskeletal injuries occurring as a result of a non-fall mechanism were primarily of the lower extremity. Shown on this slide is a graph comparing the percentage of fall and lap-related mechanisms of injury by age. The injury mechanism was a fall for 70% of children between the ages of 3 and 5. This percentage went down with decreasing age, with 62% for children 2 years old, 42% for 1-year-olds, and 25% for children less than 1. Furthermore, more than 4/5 of those injured who were coded as being on a lap or having caught their leg or foot on the slide were children less than 3 years of age, and over 90% of these had lower extremity injuries. Looking at the lap-related mechanism and lower leg and ankle fracture lines really highlights the point that we might be underestimating the occurrence of lap-related mechanisms, and that these cases were instead coded as injured when the foot or leg caught on the slide due to an insufficient narrative in the database. In conclusion, falls were the most common slide-related injury mechanism in older preschoolers. There were increasingly greater percentages of lap-related lower extremity injuries in children less than 3 years old. Healthcare providers and parents should be aware that a child's foot could catch on the slide when going down on a person's lap, and that the twisting force might cause a tibia fracture.
Hi everyone, my name is Michelle Miles and I'm a second-year emergency medicine resident at Brown University. The title of our abstract is Changes in Physician Knowledge, Attitudes, and Self-Efficacy Toward Buprenorphine Prescribing. This abstract was constructed in conjunction with the authors listed on this slide. It was funded by a Rhode Island Foundation medical research grant. We do not have any conflicts of interest to disclose. Buprenorphine is evidence-based treatment for opioid use disorder. Despite this, only roughly 20% of patients with opioid use disorder receive some sort of specialty care, and fewer than 35% of those receive medications for opioid use disorder. The ED provides an important point of contact to deliver this life-saving treatment. ED-initiated buprenorphine, in fact, has been shown to significantly increase engagement in treatment and reduce illicit opioid use. Several barriers and facilitators to ED buprenorphine have been identified, some of which are listed on this slide. Our interventions try to focus on improving facilitators and reducing barriers. The objective of this study was to evaluate changes in emergency medicine physician knowledge, confidence, and self-efficacy about buprenorphine prescribing and working with patients who use drugs after implementation of an ED buprenorphine quality improvement initiative. The Quality Improvement Initiative included didactics at residents and faculty conferences, buprenorphine protocol that was listed in all pods of the ED, a peer-to-peer warm line for physician consultation, and monetary incentive for completing X-waiver training. At the start of our study in June of 2019, an anonymous web-based survey was administered to EM providers. During the following year, our interventions were implemented, and then in May of 2020, the same survey was redistributed. Results were analyzed descriptively, and then independent sample t-tests were used to compare pre- and post-survey responses. During this time, we also tracked provider waiver course completion and monthly buprenorphine prescribing. The survey was based on the theory of planned behavior, which is a very common framework used to understand behaviors, create behavior change, and aid with intervention implementation. Each survey question corresponds to an element of the theory of planned behavior. Corresponding survey number is noted below the corresponding theory component in the figure shown. 56 of 95 attendings completed the pre-survey, while 67 of 95 completed the post-survey. 56 were included in pre-survey analysis and 60 in the post-survey analysis due to missing data. Demographics between the two groups were similar. Pre-intervention of surveyed providers, 48.2% had completed their X-waiver training, while only 30% had went on to receive their X-waiver, and even less, only 7% reported ever prescribing buprenorphine. Post-intervention, 81.7% of surveyed providers had completed their X-waiver training, 70% went on to receive their X-waiver, and 38% reported ever prescribing. We also observed some important changes within our department. Total waivered adult EM providers out of our current total of 94 increased from 12 to 71, which represents a change from 12.7% to 75.5% of waivered providers. We also saw an increase in monthly ED buprenorphine prescriptions between 2019 and 2020. In 2019, monthly prescriptions ranged from a total of 2 to 8, while in 2020, it ranged from a total of 5 to 22. Physicians were asked questions regarding their confidence in ED buprenorphine prescribing and working with patients who use drugs. They answered the questions on a scale of 1 to 5, with 5 being the most confident. Pre-intervention, providers reported an average confidence level of 3.4. Post-intervention, the confidence level increased to 3.9, and this difference was deemed to be significantly different. Physicians were also asked questions about their knowledge around ED buprenorphine. In particular, they were asked, ED initiation of buprenorphine in appropriate patients has been shown to improve outpatient addiction treatment follow-up, which is true, be cost-effective, which is true, and increase frequency of ED precipitated withdrawal, which is false. Physicians pre and post seemed to answer the first two questions in very similar numbers. What's interesting is that more physicians correctly identified that ED buprenorphine does not precipitate withdrawal when administered correctly post-intervention. Differences in mean knowledge score were significantly different. Physicians were also asked questions regarding their self-efficacy and attitudes in ED buprenorphine prescribing and working with patients who use drugs. Again, they were asked to rate their self-efficacy and their attitudes on a scale of 1 to 5, with 5 being the most self-efficacious or the more positive attitude. What we saw is that physicians' self-efficacy and attitudes did not change, and we think this is in part due to the fact that our interventions did not focus on motivational interviewing. In conclusion, physician confidence and knowledge increased while self-efficacy and attitudes were unchanged. Number of waivered prescribers and monthly buprenorphine prescriptions also increased after our intervention. Future efforts are needed to improve provider skills, self-efficacy, and attitudes toward working with patients who use drugs. We are currently working on implementation of a buprenorphine home initiation protocol to continue to break down some of the barriers to ED-delivered buprenorphine. Here are some of our references, and thank you all so much for your time.
Hello, everyone. My name is Leslie Barnard. I'm a first-year doctorate of public health student at the Colorado School of Public Health and a research assistant at the Department of Emergency Medicine. I'll be presenting on the first year of Colorado's red flag law, and I'd like to acknowledge the rest of my co-authors. Without them, this work would not be possible. I have no conflict of interest to disclose, and this work was supported by the National Collaborative on Gun Violence Research. So some background. Extreme risk protection orders, also known as ERPOs and red flag laws, have been enacted in 19 states in the District of Columbia. State-level studies in Connecticut and Indiana suggest that ERPOs may prevent firearm suicides, but robust implementation is critical for maximal effect. Colorado is one of the most recent states passing this kind of law, and it went into effect on January 1st of 2020. In Colorado, these laws allow designated individuals, so law enforcement officers, family members, intimate partners, also known as petitioners, to petition for temporary restriction of firearm access for a person or respondent with imminent risk to themselves or others. So a court can grant a TURPO, which is a temporary ERPO, for 2 weeks before a full hearing is heard to grant a full 364-day ERPO. And once an ERPO is granted, the respondent must surrender all firearms and may not acquire any additional firearms. So there was significant controversy surrounding this law's passage in Colorado. These are some local and national headlines related to the fear and debate around Colorado's ERPO law. Opponents were concerned about due process and malicious petitioning. So some counties were supportive and some were not. And some counties in their disapproval declared themselves Second Amendment sanctuary counties. So this wasn't really clear how it would be operationalized, but it ranged from county officials passing non-binding declarations to law enforcement indicating that they wouldn't serve out orders that had been issued. So our methods for evaluation basically were to obtain the case numbers from the Colorado state court system and then go to each county court system and request the individual documents for each case. Once we obtained all the documentation, we are able to abstract that into a centralized database where we had 85% inter-rater reliability. So there were 109 petitions filed in Colorado in 2020. We had to exclude 11 due to lack of information and 12 that were duplicates. So the duplicates were same petitioner, same respondent, same information supporting the petition, but that were filed multiple times. So of those filed, 61 or 71% were granted TURPOs. A higher percentage of those filed by law enforcement officers were granted compared to family. And those that were denied, the biggest reason was that they did not meet the burden of proof, followed by clerical issues. And as you can see in the flow diagram, I listed a relationship as clerical issues. So these were where the petitioner had an inappropriate relationship listed or misrepresented in their filing. So those were the ones that we are a little bit concerned about whether or not they would be malicious intent. But it turns out that only one of those filed that had an inappropriate relationship listed had legal issues or legal consequences associated with it, and the rest of them seemed to be more a fundamental misunderstanding of the law rather than, like as I said, a malicious intent. So of the TURPOs granted, 49 went on to have full ERPOs granted. 11 of those were for threats towards self, 20 were for threats towards others, and 18 were for threats towards both self and others. This is a heat map of the total ERPO petitions filed in Colorado in 2020 by county and Second Amendment sanctuary status. So the counties with the slashes through them are the Second Amendment sanctuary status counties. The county in the middle with the star is Denver, for those who aren't familiar with Colorado geography. Denver had the highest proportion of petitions filed, totaling 38 petitions filed, which is not surprising given it's the most populous county in Colorado. So of the 37 counties who declared themselves Second Amendment sanctuary status counties, 24 of those had at least one petition filed versus 52 of the counties without Second Amendment sanctuary status. And across the 2A counties, 39% of petitions resulted in TURPOs versus 63 across the non-2A counties. So a lower percentage were filed, a lower proportion of petitions were filed and approved in 2A counties, but they were still filed and approved. So our conclusions, there were a few cases of obvious misuse, and all of those that had obvious misuse were denied. But that led to us to believe that, that this supports education of the public and as well as law enforcement officers to ensure proper and easy use of this law. There were petitions filed and granted in 2A counties, and future evaluations as cases accumulate may identify statistically significant patterns. Understanding ERPO-related implementation experiences and challenges may inform policy creation and inaction in other states, including identifying how to best address concerns and facilitate the process and its evaluation. So more research and continued long-term follow-up is an important next step to evaluate the ERPO effects in Colorado. Thank you.
Hello, my name is Alexis Lawrence. I'm the Director for Quality and Patient Safety for Brown Emergency Medicine, and we'll be presenting this lightning abstract, Factors Associated with Delivery of Emergency Department Harm Reduction and Addiction Treatment. Over 81,000 drug overdose deaths occurred in the United States in the 12 months ending in May 2020, the highest number of overdose deaths ever recorded in a 12-month period, according to the CDC. Overdose deaths were already increasing in the months preceding COVID, but continued to accelerate during the pandemic. Rhode Island has one of the highest rates of overdose death in the US. Emergency department visits are a crucial opportunity to provide people who use opioids access to harm reduction services and addiction treatment. ED-based naloxone distribution and peer behavioral counseling have been shown to be feasible and acceptable, but little is known about utilization maintenance over time and factors associated with service receipt after an ED visit for opioid overdose. The impact of patient, provider, and institutional level factors on the likelihood of provision of take-home naloxone, behavioral counseling, and treatment linkage is unknown. In this study, we utilized a re-aim approach to evaluate implementation of an ED take-home naloxone and behavioral counseling initiative and identify patient, provider, and institutional level factors associated with offer and acceptance of these interventions. We evaluated program reach, proportion of eligible patients receiving intervention, adoption, proportion of eligible providers delivering intervention, and maintenance, proportion of eligible patients receiving intervention per month. We conducted a retrospective observational review of patients presenting post-overdose between 2017 and 2020 to 2 Rhode Island emergency departments, an academic level 1 trauma center, and a community ED, which combined treat over 180,000 patients annually. We utilized logistic regression to identify factors associated with receipt of intervention and Poisson regression to assess temporal trends in service provision reported per hospital. In 2014, we established the Lifespan Opioid Overdose Prevention, or LOOP program, which provides ED patients at risk of or cared for after opioid overdose with take-home naloxone, peer recovery coach consultation, referral to treatment, and, if appropriate, buprenorphine initiation. Post-overdose care is a departmental quality priority. Loop interventions are bundled in an EHR order set, and a standardized dot phrase exists for documentation aid. Providers also receive care quality feedback reminders from departmental QI nursing staff to provide patients treated for opioid overdose with take-home naloxone, behavioral counseling, and treatment linkage. There were 1,458 ED visits among 1,141 patients for opioid overdose at both hospitals from September 2017 to February 2020. Patients were eligible for study inclusion if they were treated for an opioid overdose and were aged over 18 years, not in police custody, and treated and discharged from one of the 2 study sites. Patients were excluded if they were admitted to the hospital, left against medical advice, left without being seen, or died. After limiting to the first ED visit with discharge status in the study period, 742 patients were included in the re-aim analysis of Loop. In 86% of those visits, at least one intervention was completed. Take-home naloxone was provided to the largest proportion of patients, 66%, compared to 63% referral treatment and 51% behavioral counseling. Amongst attendings, adoption was high overall. 94% of attendings at Site A provided naloxone, 90% provided behavioral counseling, and 94% provided referral to treatment to at least one patient during the study period. By comparison, 86% of attendings at Site B provided naloxone, 82% provided behavioral counseling, and 74% referral to treatment for at least one patient. At Site A, adoption of naloxone, behavioral counseling, and referral to treatment was high for both residents and APPs. Adoption by residents was lower at Site B. In the forest plot shown here, we are able to review all the significant values from the model. The model adjusts for age, gender, race, ethnicity, insurance type, month, day, and shift presenting, clinical team composition, length of stay, daily left without being seen rates, and number of ED arrivals. After adjusting for these patient, provider, and institutional characteristics, factors associated with receipt or non-receipt of services included ethnicity, insurance status, month of ED visit, and composition of the treating clinical team. At Site A, patients were less likely to receive take-home naloxone and referral to treatment with increases in daily left without being seen rates, and had a 3 times greater odds of receiving behavioral counseling when the care team was composed of an attending and either a resident or APP compared to an attending only. At Site B, patients seen in July through September had reduced odds of receiving take-home naloxone and behavioral counseling. Site B patients with private insurance had lower odds of receiving behavioral counseling, while increasing length of stay was associated with higher odds of receiving behavioral counseling. Patients at Site B who were Hispanic Latinx or seen Friday through Sunday were less likely to receive referral to treatment. During the study period, the proportion of patients provided take-home naloxone, behavioral counseling, and referral to treatment did not significantly change or depreciate over time. This study demonstrated the long-term reach, adoption, and maintenance of ED-based harm reduction interventions for individuals at risk of subsequent opioid overdose. Nearly all individuals received at least one of the 3 loop interventions, with the greatest reach being for naloxone distribution and referral to community-based treatment. After adjusting for patient, provider, and institutional level characteristics, factors associated with receipt or non-receipt of services included ethnicity, insurance status, day of ED visit, and composition of the treating clinical team. Future research that disaggregates the receipt of care into 1, offer of services by the provider, and 2, acceptance of offers by patient may inform efforts to improve access to quality care. As the opioid epidemic continues, identifying implementation strategies to improve the uptake of evidence-based reduction interventions are necessary in addressing opioid-related morbidity and mortality. Thank you.
Hello, I'm Justin Bruton, and I'm an emergency and palliative medicine physician at Wake Forest in Winston-Salem, North Carolina, and it's a pleasure to be able to present our project on variables associated with inpatient mortality within 72 hours of interhospital transfer. It may not come as a surprise, but interhospital transfer patients have a higher risk for early mortality when compared to routine ED admitted patients. In one study, this group was 2.7 times more likely to die in the hospital as compared to non-transfer patients, and they counted for almost 1/3 of inpatient mortality, even though they only represented about 11% of admissions. This study came about as a follow-up to an initial study we had done looking at the frequency of goals of care discussions prior to transfer in patients who died within 72 hours following interhospital transfer. And what we found in that study was a significant portion of patients died within 24 and 48 hours respectively. About half in 24 hours and about 2/3 in 48 hours. And when we looked at those charts, we saw a lot of the reason that these patients died shortly after transfer was that care goals were de-escalated early on in that course. And we hypothesized, what if these patients could have received more prognostic information early on, would have affected those care decisions and possibly the decision to transfer. And even though as emergency physicians, we oftentimes can sense when a patient may be at risk for impending death, in less obvious cases, say a devastating head bleed, but say somebody with sepsis, trying to prognosticate early on can be problematic and controversial. So how do we deliver that prognostic information early, but do so in a manner that's justified? Now, one study I really liked that addressed some of these ideas was one by Kei Uchi and others, looking at outcomes of intubation in older adults. And one of the things I really liked is they came up with this visual aid that helps to show families these are the outcomes for patients in this age category when they undergo intubation. So many die in the hospital, so many get discharged home, and so many get discharged to a nursing facility. And it was, I think, a really good attempt not only to assess these outcomes, but also find a way to deliver this information early when it might affect care decisions. So the question we had is, can we obtain prognostic indicators in a time-sensitive fashion that's going to use data that we would likely have with any sick ED patient? And this was really a preliminary study to look at proof of concept for this idea. So for this study, we looked at patients transferred to Wake Forest Baptist Medical Center from October 1st, 2016 to March 31st, 2020 who died within 72 hours of transfer. And we needed to have complete data for the following: a complete metabolic panel, complete blood count, vital signs, and then information on use of vasopressor agents or mechanical ventilation. So out of that group, we had 54 patients that met study criteria, and this group was age and sex matched with a control group of patients who were transferred but survived to discharge. These groups were then subsequently compared by univariate and multivariate regression analysis to see which variables were most closely associated with death within 72 hours of transfer. So what we found out of those data points was that use of mechanical ventilation, use of vasopressor agents, tachycardia, low bicarbonate level, increased anion gap, low calcium level, and leukocytosis were all associated with the group that died within 72 hours. In multivariate analysis, we found a significant difference with vasopressor use, tachycardia, reduced bicarbonate level, and leukocytosis. So this was a relatively small data set, and in the limitations, I'll explain some of that further. And even though only 4 data categories show significance in multivariate analysis, we think in subsequent study by addressing some of those data limitations, we could potentially yield more significant results. And the fact that with a relatively small data set, we were still able to see distinguishing features between these groups, I felt like was a successful result and does help us in planning subsequent study to see if it's going to be a viable option. So the limitations, as I mentioned before, this is a single center study, and one of the issues that we had that was kind of discovered in the midst of getting data collected is that the way the data filtering is set up probably excluded a lot more patients who could have been used, and we would have had more data points because I think the data is there, but anybody who's done much with retrospective data acquisition can tell you that sometimes a small change in filtering and other things can make it very difficult to get the data you want. So we're still refining that further. The other thing we didn't do was incorporating comorbidity matching as part of our preliminary data trial. So the next steps that we're working on now is a broader pilot study using facilities that are within our same affiliate hospital group that all use the same EHR system, because I think this is going to help us refine our data set further and get some of those missing data points. With a bigger data set, we'd like to apply some machine learning analysis to be able to get an idea of what this relationship looks like, and we're going to test that with prospective enrollment. In closing, I'd like to thank my collaborators, Dr. David Klein and Dr. Jennifer Gabbard. I'm also supported by the National Foundation of Emergency Medicine in this work, and I'd like to thank the Wake Forest Clinical and Translational Sciences Institute for the data extraction portion of this project. Thank you.